Looks like we are technically live. And let me go live here. Okay. How's it going, Dr. Salem?
It's great. It's great to be here again. I'm glad to kick this one off. I'm excited about this topic.
Yeah. Well, talking about that, we'll remind people again that everyone who at least comes on here live again doesn't have to show their face. That they'll be in our raffle that we're gonna have, and that gets you 5 entries. And if you send a question and we put that question online that we talk about on the show, you'll get 1 entry into the raffle. And so obviously 5 is better than 1, and so hopefully you guys can get on this show and can help us ask questions and things like that. So anyways, we do have some fun stuff to go over tonight. We're going to be talking about some topics. But what I'm going to do is, I don't know, Dr. Salem, do you want to go first, or we were going to talk a little bit about the implications of ovarian reserve testing. I think we'll just kind of talk on that, and then we'll open up to other people. But just what does it mean? I mean, does it mean I can't get pregnant if my AMH is low? Does it mean I won't be successful? And so, thought we'd start on that. And I don't know if you want to go first, me go first. And you and I were too polite. We always give each other the first choice.
Yeah, I guess I'll be the rude one today. How about that? I'll just butt in. Yeah, it's a really interesting topic. This idea of ovarian reserve testing. It's interesting not because it hasn't been around for a while. It's interesting because it's really come to the forefront of the public conversation recently, especially over the last years. We see a lot more people talking about ovarian reserve testing on, Facebook, Instagram, social media, in the news. There's even been companies that have come out with kind of at-home ovarian reserve testing, or kind of ovarian reserve testing that you can order for yourself. And I think that'd be a great part of our conversation today to talk about that. And obviously, this has always been a big part of the field of fertility, to kind of understand, where the ovarian reserve is for a certain individual. But we also use it in many ways to personalize IVF, for the dosing of medications, for a whole variety of reasons. Ovarian reserve testing is also becoming more important in terms of egg freezing, in terms of understanding the relationship over time for a certain individual's ovarian reserve, or AMH maybe, or follicle count. And we'll talk about each one of these parameters today, but that's just kind of my little intro spiel. But I'd love to hear kind of what you think about where we are in terms of ovarian reserve testing in comparison to maybe the way we would have thought about it, I don't know, let's say 10-15 years ago.
Yeah, absolutely. And, before I even go over what I have to say about ovarian reserve, I just want to, again, point out to patients, or just people watching this show, please, come on the show. Again, you get in our raffle, but tell us your numbers, tell us your ovarian reserve, see what we say about it. Seeing other patients come in and tell us their numbers and their age, we'll be able to talk about those situations. And it's only going to help people, because they're going to say, hey, I'm also that age and I have that ovarian reserve. And that's going to help people a lot more than you and I just talking about it. So, ovarian reserve is one of those things that I feel like sometimes is completely misunderstood. It's looked at as this kind of, is this going to help me get pregnant? Am I going to have a hard time? I think one of the biggest disappointments I have with ovarian reserve is I've seen fertility clinics actually use it to push people to do things. So they'll say, oh, well, your AMH is 1.4, and for your age, it's too low. You have to do IVF. And that's just not true. Ovarian reserve, as I always joke around and say, is that it's really a measure of who can make the most eggs. It's a kind of like who can make the most egg contest, and that's where ovarian reserve plays a part. I've seen people with horrible ovarian reserve get pregnant. In fact, I see people come in all the time who've had 4 or 5 kids, and they want to have another child, but they want to pick the gender. And, they're like, well, I have no problem getting pregnant. I'm going to be this great candidate for IVF. And then I look at their ovarian reserve, and I have to tell them that they'll only make 4 or 5 eggs, and they don't understand it. How can they get pregnant so easily every month when they try, but they're not a great candidate for IVF? That's why I explained to them, when it comes to ovarian reserve, it's a measure of how many eggs they'll make. But to get pregnant, you don't need that many eggs. It's just in IVF, it means you can't make as many, you may not do as well. So that's what that association is. But it's been really pulled to make people think that they're not able to get pregnant. And that's just not true. And so, like you said, we'll kind of go over the different things. I think, I look at it a little bit different. I think sometimes I'm such a nerd and I look at things so analytical that maybe I'm looking at too much. But I usually break the three groups into, as you mentioned, antral follicle count, AMH, and cycle day 3 labs. And the way I look at each one is AMH is kind of like it's a weird number because it does associate with better chances of getting pregnant with things like ART treatment. But it doesn't define the person, right? You can have a low AMH and still get pregnant, but what a low AMH does usually mean is though their fertility reserve is probably going to go down faster, right? Versus someone who has like a 2, I'm not too worried about the next few years, as when you were mentioning about egg preservation. Whereas with day 3 labs, those are the ones that scare me about now, because if that FSH is high, then I know currently at this moment there are issues and that I may not be able to get them to stimulate as well, which we'll go into. And then the last thing is antral follicle count. I truly think antral follicle count is probably the best measure in my mind of egg reserve. But the problem with it is that it depends who's doing it. If I do it, I think it's the best thing because I don't count little tiny follicles and tell someone they have 14 eggs. There's a doctor in town who tells everyone they have like 20, 30 eggs. And then they could be like 48 and they'll still tell them that. But if you have someone who's really doing it correctly and only measuring the antral follicles, then I truly think it's one of the best measures because it tells you a lot of things, how many eggs they have available and what you're expecting. And it tells you if they have low ovarian reserve. And so anyways, yeah, I love that, you and I kind of have that conversation of how do you use it? What, do you use it absolute? Does it, and then I think as you mentioned the point, the numbers might make us start with a certain idea. But what we do is still as doctors, we change as we go. And so I could think someone has a bad ovarian reserve and later when I go, well, you're still stimming well. So love to see what you have to say about that. And again, hope people come on here and share their ovarian reserve with us so we can kind of look at those specific situations.
Yeah, no, I like that. I like that idea of, kind of thinking about the antral follicle count in terms of, sort of an operator dependent measure, but one that is really, really important. Especially if you're sort of lucky enough to be able to have the same person doing the antral follicle count over time. The AMH, one of the interesting things about AMH, anti-Mullerian hormone, is that, our understanding of AMH has sort of refined over time. So in the very beginning, I think that there was, this overwhelming idea that your AMH, starts high and it just gradually goes down in a kind of a linear way. And, practically speaking, after you see tons of people's AMHs over time, you realize that it's not quite A, that linear, B, depending on the lab where you have the AMH drawn, you can actually have pretty different outcomes. Like the same day you have your AMH drawn at lab A and lab B. And because of the way they do that analysis, they can get totally different numbers. So another part of this is probably, if possible, following it over time. If you're going to follow it over time, maybe trying to at least go to the same lab or taking that with a grain of salt if you don't. I think the really interesting thing about AMH is that it is predictive of outcomes with IVF, but it's not predictive of folks who are trying to get pregnant who have never tried to get pregnant before. And there was actually a really cool study, very elegant study that was done in which they took 2 groups of people, one group that had low AMHs and one group that had normal AMHs. Neither group had tried to get pregnant yet. And they were like, well, for sure, the group that has low AMHs, we're expecting them to have lower pregnancy rates at the end of, 6 months, a year. And what they actually ended up finding out was that there was no difference, that the groups at the end of a year got pregnant at the same rate. So it's interesting because going back to your point, Dr. Amols, I think there, unfortunately, is a lot of like fear mongering around you getting your AMH drawn. Maybe you're like a 27-year-old woman and you go get your AMH drawn and it comes back and it's lower than, let's say, the average for your age. And I think what happens is a lot of people get really, really worried about that, really scared about it. And at the end of the day, we have to remember that this is not a natural fertility test per se. It doesn't tell you what your natural fertility is going to be when you try to get pregnant. And there's a lot of other factors, of course, other than the ovarian reserve. But the ovarian reserve, what it tells you is limited. But as long as you know what that limited scope is of what it's telling you, then it's a great number.
Yeah. It's interesting. I'm sure you get this question asked a lot, is how can I improve it? And a lot of times I always try to explain to people, it's not really a question of improving it sometimes, because, I always explain it's not the FSH level that worries me, meaning like, can we get the number lower? It's what it represents. And I mean, I tell patients all the time, I can get anyone's FSH level down. You can be menopausal and I will get your FSH level under 10 easily by putting you on things like birth control or estrogen. But what we're concerned about is what it represents. And when it's high, the problem then is that it means it takes more hormone from your brain down to your ovary to make one egg. And so if it takes more hormone, then obviously it's going to take more hormone to get more eggs to grow. And so I always look at cycle day 3 labs as kind of like the response. How well will they respond to medications? I look at the antral follicle count as what's the potential every month. And then I look at AMH as kind of like longevity, like you said, and it's just kind of AMH for me is more of a test that helped me make sure the other labs were, are correct, and tells me a little bit about the time limit. Because if I have someone that's good at cycle day 3 labs and good at antral follicle count, but has an AMH of, let's say, 0.7, in my mind, I'm thinking, okay, I can get them pregnant now. But what worries me about that 0.7 is they may not have 5 years, right? And so I have to at least let them know, listen, there's no study here saying that you're definitely going to go into menopause earlier, but you may have a harder time 5 years from now because there could be a faster decline because the AMH level is low. And as you know, and I know, there are a lot of things that can make it go lower. So like after a retrieval, there could be some problems. So it's also important to take all that stuff into context. But I think the point that you and I are saying is look at these numbers as guidance, but not absolute.
Mm-hmm. I think it's, on your point there, Dr. Amols, I think it's important to think about also these things that do make the AMH artificially lower, because sometimes we draw an AMH and somebody is like on birth control pills, or somebody may have, recently had a very acute illness of some type. And these are things that can actually kind of artificially lower the AMH. Now, when I say artificially, what do I mean by that? I mean, you come off of the birth control pills and we see the AMH kind of rebound. It comes back a little bit. And that's kind of your true AMH. And so, again, there are parts of this that are a little nuanced. And so, when companies are out there and telling people, hey, just get your AMH drawn, it's going to tell you so much information. I mean, I think there's a little bit of truth to that. I think knowledge is power for sure. And if there is some number out there that can help, that's wonderful. But we have to know how to interpret that number. And so that's where it's really important to know, like, hey, were you on birth control pills? Were you, was this going on? Was this going on? And so these are all things that can really play a big role as we think about it. But
so let me ask you, you get to pick one test. And obviously no one ever just picks one test, right? Obviously you're going to do the test that you need. And most of us do all of them. But if you could pick one, what would be your test that you would want to rely on? Would it be just AMH? Would it be just antral follicle count?
If I were going to do just one test prior to an IVF cycle.
Yep.
Ooh, that's a good one. I'd probably go with AMH.
Interesting. Yeah, I still go with antral follicle count only because I feel, and I've mentioned this to you before, and I have no proof of this, but it makes plausible sense. I feel AMH, especially like when you have endo, can be elevated. And it makes sense because it comes from granulosa cells, and granulosa cells are going to be higher, sometimes with people with endo. And I'll see these women with very poor ovarian reserve, meaning like, antral follicle count like 6, high FSHs with great AMH with endo. And I feel like it's something without seeing the patient, but there's just something about seeing those follicles and knowing that they're, what their their baseline would be, just it helps me kind of figure things out a little bit more. Because in the end, I feel like I can get anyone a stim eventually, unless their FSH is, above 30. What makes you like the AMH so much? I mean, again, that's probably, I would say, just so everyone knows, probably most fertility doctors would say that. So I think Dr. Salem is picking probably the smarter choice, where I'm still part of that old gang that feels that antral follicle counts are so amazing.
So let me be clear. I would never do an IVF cycle without an antral follicle
Correct.
count and an A match. But I would say this. One thing that is nice about the AMH is it really gives us an idea. It gives me an idea of when I stimulate, this patient with the medications, I have a good sense of where my starting dose will be based on that AMH. And I'll use that along with the age to just kind of have a very good sense of where we should be early on in the cycle, to say, okay, so then I'll do the ultrasound and I'll say, okay, this is kind of what I would expect, that this many follicles would be growing in a 37-year-old with an AMH that was 2.0. And this kind of eyeballs right. The antral follicles, the one thing about them is you can also use that information, but sometimes it's going to be a little bit harder, a little trickier to pick kind of like that perfect dose, I feel, of the starting dose. Now, just because some women may actually have a little bit of a higher follicle count, but have a lower AMH than you would have expected. So again, I mean, this is all kind of at the margins. I think probably, 95% of the time you could use one or the other and you'd be pretty spot on. And this is the interesting thing about, of course, where AI is going in our field, using artificial intelligence to put all of these things together to really kind of hone this down perfectly. But yeah, that's just my 2 cents on it, I guess.
Yeah, I mean, I don't think there's a wrong or right. And I'm a long time ago, they actually did a study where they actually went and looked to figure out, is there a test that's better than the other? And when they did this test, they looked at all those different parameters, and what they found was there really wasn't anything better than the other. And that, I think, inhibin, we found that wasn't very useful. But when it came to AMH, antral follicle counter, cycle day 3 labs, they all generally, were useful. But I do agree with you. I think AMH for most people, especially if you're not doing the antral follicle count yourself, is going to be the most useful. And so I think, just for our last part, because we could talk forever and we'll bore everyone to death. For implications to patients, I would tell you, I mean, the numbers that worry me, I think this would be kind of good for Dr. Salem I discuss, is for anyone who is going through and gets their ovarian reserve, what numbers should they be worried about? So I think we should break it up into like age 35 and below, and then between like 35 and 40 and above 40. So for me, I mean, like antral follicle count, as long as people have, I want to see at least 10 and above. I expect there to be a decline. People under 35, I'm usually expecting to see more like a 12 to 16 antral follicle count. What do you think, Dr. Salem, for under 35?
Yeah, I agree with those numbers. I mean, the antral follicle count is one where if you're under 35 and now we're kind of in the lower single digits per side, then I get a little bit concerned. I get concerned not because necessarily the egg quality will be bad, right? And so that's an important distinction. But because we know that by and large, with IVF, to a certain degree, the more eggs that we can get, the more efficacious the cycle is, the more efficient the cycle is. So when we start seeing follicle counts that are, pretty far off from the average and significantly below, then I start to get a little concerned. Doesn't mean it won't work. It just might be less efficient. It might take 2 cycles instead of 1.
Absolutely right. I was actually doing some research for one of my podcasts coming up about how many eggs do you need to get pregnant. And one of the things you said exactly is, if you are under 35 and have at least up to 9 eggs, 5 to 9 eggs, your chances are very high. And even up to 38, it was still decent, but it's after 38, you really need more to really have a high chance of success. Should anyone be worried about a cycle day 3 labs with their FSH being above 10? I know a lot of people get worried about that. I really don't even get concerned until we start getting above 12, meaning like, even if I see 11, I don't even blink an eye at it. But, if I see 12 and someone's, 29. I'm like, okay, that's a little unusual. Why is that elevated? 12 in someone who's 41. I'm going, well, it's kind of expected, not too surprising. But I'd love to know your opinion. I mean, what number do you kind of, even if they're younger, do you get a little bit concerned about? Even though we know it should be under 10, I don't get too concerned about it until it starts getting above 12.
Yeah, that's right. I mean, again, I think the FSH too, like when I think about those three numbers, right? AMH, antral follicle count, and FSH, I find that the FSH is the one that kind of bumps around the most.
Yeah.
If you did 3 months in a row, you'd probably see the most percent variation, we'll call it, in the FSH compared to the other ones. So sometimes you might just be catching like quote unquote a bad month or something of that kind. It also has to do with some of the physiology around when you're catching that number. So the FSH doesn't get me, too excited when it's below 12. It gets my attention, if you have a 28-year-old and you're expecting it to come back, yeah, below 8 to 10, and it's hanging out at 12. But I would say there's another number that for me really is important, which is an FSH above 20. I find that with FSHs above 20, I really have a much more careful conversation about the chance for cycle cancellation with my patients. Once
Yeah.
we see the FSH go above that, we can see more responses like a dominant follicle, building, and then we'd have to potentially cancel the cycle, or maybe a lack of response to the medications. There's a lot of little tricks that one can try, but I think that's one that really gets my attention when we're above 20.
Yeah.
Between 15 and 20 is that it's kind of that, there's a yellow flag there. It's not quite the red flag, but it's a yellow flag. I'm a little bit more nervous about that as well, but definitely better results than above 20.
Yeah, and then make sure people know. I mean, I've got people with FSHs in the 28. So I mean, it can happen, but what Dr. Salem is saying is that, and I agree 100%. You start having to have conversations like this may not work type of thing when it's above 20. And interesting enough, not even like 10 years ago, anyone who had an FSH above 14, most clinics wouldn't even do IVF with them. So I mean, we've really come a long way and shown that you don't have to have FSH isn't going to be the make or break thing, but anyone who has an FSH of 14 or above, and you're under 42, you definitely need to see a fertility doctor, because that's not going to be a normal number at that age. And then I think the very last one I'm going AMH, so we don't keep going on, is I always tell Bill 1. I mean, again, do I want to see above 1? I do. I like to see 1.5 at least, and for people and above for who are younger, don't expect any higher than like 2.5, 2.5. But 1 is kind of my number. I'm like, as long as it's not under 1, I feel like I'm never too worried about people. Once you start going under 1, that's when I start getting a little bit more concerned. I just wonder, what do you think too? And again, I'm giving these very general numbers. When I say concerned, so people know what I mean like concerned, like, wow, this is gonna be harder than I expected. Not concerned like you're never gonna have a kid. Just concerned like, okay, this is gonna be a little bit tougher now. This isn't gonna be just so simple.
Yeah. Yeah, no, I definitely agree with that. I mean, I think even between zero point 0.5 and 1, I mean, we've had such great success with our clinic and IVF and our success rates. But you're right. I mean, it just means that there's a little bit more margin where we might not get as many eggs. We might not have as many embryos to maybe genetically test. You might not end up with a genetically normal embryo because you only tested 2 or 1. I think, there's 2 other little categories that I get concerned about. One of them is when we drop down to the AMHs that are kind of below that 0.25. Like there's a level there where you start getting at these very low egg counts when the AMH is that low. And then the other one is undetectable, right? So sometimes the AMH will come back and it's undetectable. And believe it or not, you can still kind of, based on the antral follicle count, based on some other things like the FSH, you can still try to do an IVF stimulation. But at that point, I like to call it a trial of stimulation, right? Like we're trying to see if something will grow here. But that's the part, again, where it's kind of undetectable, where I get really concerned. Now, undetectable at 35 is different than undetectable at 45.
Yeah, absolutely. Yeah,
Mm.
and it's funny you were saying that, because I'm actually a little bit, I want to say the opposite And AMH never bugs me. Even when it's undetectable, I'm never worried if they're younger, because I know in the end, I mean, I've had so many successes with that. So undetectable makes me worried like you are. And I still tell them like, this is going to be tough, but I'm not scared that it won't work. But the ones I get scared about are when I get the FSHs that are just, you get to like a 40, 50. I mean, there's times I can't even get eggs grow anymore. And, especially if someone's not getting a period anymore and a high FSH, it's worrisome. But at least for everyone who's listening, I mean, the important thing to understand is these numbers that we're telling you are just to help you know when you need to see a doctor, and, if taking a little bit more concern about it, but nothing's ever going to stop you from getting pregnant, meaning it can still work even in all those situations. And so I'll give you the last word, Dr. Salem, because I know we've been talking forever, and I'll get Ari on the stage here so we can start talking to some of these people.
No, I mean, actually, you know what? Let's just dive right into it. I think that we have a couple,
Sounds good.
listeners that, yeah, let's just dive right into some questions.
All right, let's get to it. So we have Catherine R. She's on stage. We're going to add her.
Fantastic.
Catherine?
You there, Catherine? Hey, Catherine. All right. I don't know if we can hear you. No, we're not hearing you at the moment. So what we can do is Ari can kind of work with you in the background. It might be a microphone issue, and then we can move on with someone else just for the moment. I'm sorry about that.
Okay, Catherine H. We're going to bring you on. Okay, perfect.
Okay. Hey, Catherine, how are you doing?
Hi, I'm good. How are you?
Hi.
Oh, fantastic. Well, what questions do you have for us?
The dog is hearing other voices. So I am, just to give it a little history, Dr. Amols, we talked not too long ago, but just went through my second retrieval and didn't go as planned. But I'm about to be 37 and my AMH is on the lower end. But this last cycle, my FSH was normal, and I've never had a problem with FSH being abnormal. Just know that my AMH is low. So Dr. Salem already kind of touched on this a bit, but just saying, different labs can kind of sometimes come back with different numbers. I've seen my AMH go up and down. It's been tested 3 times since August of 22. So I've seen it kind of go up and down a couple of times. So do you think that this last round was just a fluke with those numbers? And is there anything I can do to kind of, I know AMH will never go up, but is there a way I can stall it and kind of help with that egg quality?
Yeah, it's interesting. I'm going to start, Dr. I'm sorry to jump in front of you there. I know Catherine very well. You ever heard the saying, the proof is in the pudding? In some ways, that to me is sometimes even more important. So someone can have a great FSH, they can have a great AMH, they have a great antral follicle count, but in the end, how you stimulate really tells a lot of the story. That becomes a test. And I think sometimes we forget that because, people come to me and say, well, what if I get my AMH higher? But still at the point, you have to look at and go, but what happened during the stimulation? If we're using high doses and we're doing all these things and we see eggs falling out and we see not as many growing, and out of respect, I won't talk about your case directly. Obviously, you can say whatever you want, but out of respect, it tells us more of a story. So I've had people where I'm scratching my head going, why are they not responding? The numbers look good. But this goes back to what Dr. Salem said is these things do have fluctuations. FSHs can look good sometimes and bad other times. And that's why once I do a cycle, all that stuff I throw out now. Now I look at the cycle and I use that to help gear me then what to do next, because that's the proof is in the pudding. And I'd love to see what Dr. Salem says too. I'm sure he probably does something very similar, but I'd love to know.
Yeah. No, I think definitely I agree with this idea that your IVF stimulation, kind of how you respond to the medications, especially for couples, women who have gone through 2 cycles. So I usually say like 1 cycle, it can be a fluke, you can have a poor response for one reason or another, etc. But if you have 2 cycles and you're like, we did everything right, everything looks good on paper, everything went according to plan, but we're still getting less follicles, less eggs to grow than we want. That's usually pretty predictive of kind of future cycles. And so there are these kind of cases where your AMH might look really good, or all the numbers might look really good, and you're getting a result that looks a little bit different than what you would anticipate. And short of, something unusual happening, when you're getting, kind of best of class treatment, which of course you are with Dr. Amols, that the best things have been tried to get the eggs to grow. And so there's even been guidelines created that one of the parameters is, if after 2 cycles of IVF, you've gotten less than an X number of eggs, then you're kind of a poor ovarian responder. And that kind of puts you into a subclass of people going through IVF. Again, doesn't mean it can't work. Of course it can work, but it gives us some perspective about how to approach things strategically.
Yeah. In your cycle, Catherine, which I can share, your cycles were separated by some time, right? And so, there's a decrease in ovarian reserve. And so we were actually more aggressive trying to get the better response. We actually got less response.
Yeah.
And that's not because so much of the protocol, but part of the fact is that the ovarian reserve decreases. And one of the things I told you, and most people don't realize this, is that you are, out of state now. You weren't originally. But if you were, one of the things I like when people are in state that I can see is sometimes when I do the downregulation scan, I know Dr. Salem does the same thing. If it looks bad sometimes, I'll just say, don't go through this month. So I'll look and go, I know she can make 8 and I'm only seeing 4 follicles. I may say, listen, let's not go this month. I don't know what it is. Your body looks slightly different. And here's the most frustrating thing, Catherine. You can do the exact same thing 5 times and get 5 different results. And so this is where, unfortunately, I get a lot of the credit. And I know Dr. Salem gets a lot of credit when people get pregnant, but some of it is just also your body, what it's doing that month. And sometimes it's not the protocol we even do. It's just that month your body did better. And unfortunately, as you said, it was definitely disappointing and not what we expected on this last cycle. And we were obviously hoping for more. And as there was a lot of dropout, which was crazy. I mean, even the high doses, you had follicles that we saw in the beginning that were just not growing and falling away. And that is part of a test where I make that point that shows that kind of diminished ovarian reserve, that even the follicles getting medication were still not growing and falling backwards. And that is a sign, again, of that diminished ovarian reserve. And, I always pray for you, and I pray for everyone and wish you better. And again, I am so sorry too. Like I said.
Thank you, Dr. Amols. Is there anything obviously meds, prescription meds will be called in, for another retrieval cycle, but are there supplements or anything that I could do on my end in preparation for a possibly 3rd retrieval?
There absolutely are. And I know Dr. Stone and I, we've talked about this on another episode one time, is that, CoQ10, DHEA, making sure you have, your B vitamins, all those are good, low inflammatory diets. It's just always important. And I don't say this because I don't think there's some benefit. There's always some benefit. I just think it's always important for people to remember. It's not that exact. I don't want you blaming yourself thinking you didn't do enough. That's not it. I guarantee you, if you were in a different situation, you had able to make more eggs in different ages, things would be a lot different. So yes, you can do those things and they will only help, but they only help a certain amount.
Sure. Okay. Thank you both. I really appreciate it.
Thank you so much. Hopefully it's not as hot in Texas right now.
It's getting there. Today was pretty warm, but probably about like you guys.
Well, thanks so much.
Thanks, Dr. Amols. Thanks, Dr. Salem.
Pleasure.
Bye. Well, no, those are always tough, man. I mean, talking about, there's nothing I hate more than, someone not having success. And it just feels like oh, I wish sometimes like, what can I do, to make it? I like I said, and she's one of the sweetest people. So I love her and her husband. They're just doing the greatest. I wish they were still here. Aria, do we have anyone else here that we're ready for? I know we tried Catherine before, and unfortunately there was a problem. Hopefully that got fixed.
Yeah, we're going to try to add her again right now.
Okay. Hello. Is it working now? No. Well, you know what, Catherine? Do me a favor.
Question there, right? Is that on the side? Is there anything that can contribute to low ovarian reserve besides age and genetics? Is that right?
Oh, perfect. We'll answer that then. Why don't you start, Dr. Salem?
Sure thing. And Catherine, you can just signal up or down for us. I don't know, tell us if you don't like our answer. You can just, so anything that contributes to low ovarian reserve besides age, this is a great one. The answer is yes. So I think that we, generally tend to think that, ovarian reserve is like set in stone, and whatever it is, that's, you've been assigned that when you were born, and that's totally not the case. There can be things that from a young age you can do to help your ovarian reserve not go down as quickly. So, for example, like healthy lifestyle things. Unfortunately, things like high alcohol intake and smoking can really decrease the ovarian reserve. And we see it. People that have, unfortunately, like smoked their whole life or have periods in their life where they were really heavy, users of alcohol will have a lower ovarian reserve. The good news is you can actually see it bump up a little bit sometimes after they've, stopped or developed healthier habits. Other things are like chemotherapy. That's a big reason that, women who have to undergo some sort of cancer therapy freeze their eggs in advance, because the chemotherapies will drastically reduce the ovarian reserve, sometimes so much that it puts some women into menopause. There are other things, though, that, maybe you're like, let's call it less in control of. Like, for example, let's say you have an ovarian cyst, and it's the type of ovarian cyst where you have to get surgery on it. And they go in there and they take out that cyst. Well, usually when we used to do these surgeries, you'd go in and you try to get as much of the cyst off as possible without taking off the ovary, but you still get a little part of the ovary, even if you're very careful, and that can reduce your ovarian reserve. So especially for women that have like really bad endometriomas or endometriosis, and they have to take off a big part of that endometrioma, you can see that there's a lowering in the ovarian reserve from surgery, because you're taking off actually a part of the ovary. Now, what doesn't affect the ovarian reserve, I think, is just as important, because I think I get people, they come in and, some women, they're like, oh my gosh, I had one glass of wine and I like every week for the last 7 years, and I'm so worried that that's why my ovarian reserve was. And I'm like, no, that's not why your ovarian reserve is affected. It's the ovarian reserve. The ovaries can still handle quite a lot of, normal life stuff, life stress, life, fun, whatever you want to call it, and still not be too affected by it. But age and genetics definitely play a huge role. And I'll leave it on one more comment, and I'll transfer it over to you, Dr. Amols. So there was recently a study that came out about AMH and ethnicity. And it turns out that there is a difference, that, when we normalized AMH curves in the past, the majority of women were Caucasian women, not all of them, but the majority that were in the studies were Caucasian women. And so we kind of normalized around those numbers. And then recently there were some studies that came out looking at women from South Asia, Indian women. And what they found there is that the normal AMH is quite a bit lower. Normal, fertile women, everything, but their AMH is significantly lower. And so I think when we see these things, this is part of a bigger picture of this era in medicine, where we're trying to pay attention to all these nuances between, you know, different genetic backgrounds and different ethnic backgrounds and these various things, and seeing if we can kind of further personalize that treatment for that person. So just that's a long-winded way of me saying, yes, there are things that can contribute to lower ovarian reserve besides age and genetics. So how about you, Dr. Amos?
I mean, it was funny the whole time we were going. I'm like, oh, I'll talk about that. Oh, he talked about that. I'm gonna talk about. Oh, he
My
talked
bad.
about that. So you hit everything. I mean, you might as well drop the mic. So I really can't add a lot to what he said. I think he said it perfect. And it's interesting when he brought up the part about ethnicities, because if you actually go to India and you talk to people there, they tell their daughters, make sure you have a kid by 30, because you're not going to be able to potentially have kids afterwards. And they know this already in their culture, that it's harder for the women to get pregnant after 30 there. Whereas we don't usually say that in the United States and stuff like that, because we don't see that. And so there's definitely a lot of truth to that. The only caveat I was going to say was definitely genetics. There's no question about that. Genetics has a huge part in my wife's family. I mean, like, really, there's a lot of low ovarian reserve. Matter of fact, my daughter, I had her actually get her AMAs drawn because I was so scared because of what I've seen in my wife's family. So there, and everyone's short in that family. And as you probably, Dr. Salem will know, is that when people are shorter, there's this kind of like connection sometimes between the X chromosome and fertility. And so, like, you think of like Turner syndrome, they're shorter and they have lower egg quality. And so everyone's short in their family. And so not seeing everyone who's short has to go running out, worrying about their egg reserve. We're talking very short. Like, my wife says she's 5 foot, but let's be honest, she's not. She's really close. But there are these, as you said, these nuances between things and groups. But the caveat I was going to say was, I don't think age causes ovarian reserve to go down, meaning, yes, there's association with it, but it doesn't mean that just because you're older, you should have bad ovarian reserve. So you can be 41 and it's still normal to have normal ovarian reserve. When we talk about, like, FSHs of 20s and stuff, that's not until you're way into late 40s, close to 50. So yes, the ovarian reserve drops because the antral follicle counts drops, the AMA drops, but it's still appropriate. But there are people who actually have lower ovarian reserve than them. And those are the people that Dr. Sam was talking about, like, who were smoking, who did these other things. So I think it's important to understand that, yes, age ovarian reserve is less than when you're 35, but it's still a normal number for you. But there are some people who are even lower than that, and those are the patients who we have to worry about. But my biggest thing would be smoking. If you want to kill your ovaries, you're like, I don't want to get pregnant after 35, smoke away. That's probably one of the biggest things. And obviously chemo would be worse, but that's not something anyone chooses. So sorry, Catherine, you couldn't talk. I feel horrible, but did we answer your question? Or okay, good. Or should I say, did Dr. Salem answer your question is really what I should say, since he really hit the nail on the head on that one. So. Well, thanks so much. We appreciate it.
Catherine. We really appreciate you coming on. Thanks so much.
Yeah, I thought you did a great job in that, by the way. Like, I'm not kidding you. The whole time I'm like, okay, I'm going to talk about, oh, he did that already. You hit that perfect. And I think, did you ever hear that? Like, I mean, going through fertility, I just want to bring this up real fast. I was always told by doctors, they're like, hey, if you have someone who's Asian, like, make sure you got to push them harder. And this is actually something that's been talked about for a long time in our field, but it was always like that kind of hush, like, don't tell them that. But so it's interesting, like it's becoming a little bit more vocal now. That's like, no, there actually are differences, and that it's not a racist thing or anything. It truly is differences between cultures. And so I thought it was a really good point to bring up.
Well, yeah, I mean, I think it's, the benefit of getting to see a lot of patients, and especially, patients from all kinds of different backgrounds, is, as a doctor, one of the things that we really pay attention to are patterns. And, you see these patterns, and then you develop research questions around these patterns, and you see does the pattern actually really exist? And I think for a long time, many people were saying things like this. Like, one thing that I remember coming up through training was, we would look at estrogen levels as they're going through the IVF cycle. And I remember when I was like a junior fellow seeing a very high estrogen level on a patient, I was like, oh my God, like, she's going to hyperstimulate and all this kind of stuff. And they were like, oh, don't worry, she's East Asian, and they tend to have higher estrogen levels for you know, the lower number of eggs compared to other women. I'm not saying that they get a lower number of eggs. I'm saying if you control for 10 eggs, you'll see a much higher estrogen level in a lot of East Asian women. And so this makes, I think this is really important. It's good to have culturally appropriate care and understand these nuanced differences between different groups, because at the end of the day, we're not trying to just have like one standard treatment that works for a standard patient, whatever that patient looks like the AI generated standard patient. Like, we have a big diversity of patients, and it's important to like understand some of these nuances that you're talking about. So, by the way, I'm going to let you go first on the next one, because I definitely did not mean to steal all the.
Oh, I want to get hard too. It's just funny, like how I'm like, man, he's nailing this one. So I wish I could help a little bit more, but wasn't able to. So anyways, all right, you can come back on. I just thought it was kind of an interesting thing, because we do get patients all the time of like, my favorite one is I'll have Hispanic patients will say to me, I'm Hispanic. Why am I not able to get pregnant? And I'm like, well, that's a stereotype. But as Dr. Salem said, there is a little truth when you normalize everything. Images do tend to be different in different cultures. So.
Yeah, that was really good. Okay, so we're going to bring Ashley to the stage. Are you ready, Ashley? Okay, perfect.
Hello.
Hey, Ashley, how are you doing?
I'm good. How are you?
Fantastic.
Great.
Good. I just wanted to come on. First things first, I have done 3 IUIs with Dr. Amos. Started in January. All 3 obviously failed. So now we are on to IVF. We were offered the opportunity to do the IVC, but we decided to do without, because we do want to have more than just one kiddo, and we don't want to go through the retrieval more than one time if we can avoid that. So very new to the IVF land in all things IVF, so I have a lot of questions. But first things first, a year ago, so when I was 28, I did have my AMH levels checked to be on topic here, and my numbers were 3.97. Based on Google, it says that that's low for my age, but I don't know what your guys' thoughts are on that. If we could start with that.
So that would be difficult to know. There are 2 different ways you can look at AMH. So there is one that's from Europe, and their numbers are a little bit different. And so if you were potentially looking at European values, which they use instead of, correct me if I'm wrong, Dr. Salem, but I think it's the difference between deciliters versus, I think the other one is in liters or something like that, is what makes the difference in it. But their numbers that are normal are going to be higher. That's going to be closer to like 3 times the number. So it'd be, like in a 12 or something like that, or like a 6 to 9. So it could be why, but no, that is not a bad number. And again, it must have been either bad information Google pulled up, which is impossible, because Google is supposed to be smarter than doctors. So I don't know how that would be possible. or likely it was probably that European, I think, one that maybe it might have been using that as its metric, because I've done that before and I've actually seen that when I pull up AMH. So.
Okay, perfect. Another question I have, so we're taking quite a stretch of a break, just because of timing and when my cycle started to when I got the consult to compare and contrast the options, and now lining up for the next retrieval. So I will be starting birth control with my May cycle. And then I was told that we'll start stims in June, but will June also be the same month that the retrieval occurs? Or would it land in July? And then I think they said I wouldn't transfer until like August sometime. Does that sound correct?
So I think there's a question that asks about, I think we can go into about IVF. And so I'm going to put you off the stage for a second here, just so we can kind of answer that question. But I think she brings up a question of like that process, right? So her process she's talking about is priming first, and then going into stimulation. And so she's asking, when will that retrieval be? And so I think the important thing to understand is not everyone does it that way, right? So there are things, different types of ways to prime. In general, yes. Usually what happens is you start on a birth control, and the purpose for the birth control is to synchronize the eggs. It also does things where it actually downregulates but upregulates receptors. And so there's a purpose for it. And then usually once you start the stim, it could be the following month, but every clinic does it different. So at our clinic, we start, maybe the month before, and then they do the retrieval. If you start early enough in the month, like let's say on day 1, then potentially you could still retrieve in the same month. But in general, it usually is. Now, some places they do what are called cold starts, where literally the day you start your period, they start you on day 3, and you start the stimulation. And so you're starting the stim and the retrieval in the same month, but they didn't do the priming the same way. And I mean, there's multiple other ways, but what do you think, Dr. Salem? I mean, what do you have to say about that? I mean, I think that was kind of where her question was going, was how, how does that work? And then, yes, usually the following month, if you're doing a frozen transfer, you're going to do the transfer. And the thing that's important to understand is it's the 2-week period, which is why it's so long until the transfer. The transfer itself only takes up to 3 weeks. 2 weeks to build the lining, 5 days of progesterone started, but you have to wait those 2 weeks to get your period. That's what makes it that 5 weeks.
Yeah. I mean, that's how I understood the question as well. One of the most asked questions, I think, that comes up in our consults in our field is like around timing, because I think for a lot of people, timing feels like a black box when they start the process. And so fortunately, the nurses really, do the hard pull here. They really, really explain the timing of this so well. But in a very general sense, and tying this back to the ovarian reserve, the ovarian reserve does tell us a few things about the types of protocols that we'll use. And the types of protocols we'll use dictate to some degree the types of priming that we'll use. So again, it's really not like one protocol for everybody and everybody kind of does the same thing and they all take a walk around the block together. It is highly varied in that kind of thing. And so when we think about priming, there are times when you start priming with the period. There are times when you start priming with ovulation. There are times that when you start, you don't do any priming, just like Dr. Amols was saying. So it really depends a lot on that first part. But the stimulation cycle, I always say, at least this is what I kind of like to say. I usually say it's on average 10 days, but plus or minus a few days. There's variation there. It rarely goes much longer than that, and it's very rare that it's much shorter than that.
For time's sake, just because I know we got other questions to go, people, she did have one more question, which I'll bring up while we're here, and then I can definitely go on to other questions. Is actually, you were asking about PCOS and that, how does that affect the egg during it? Is that correct?
Yeah, and I've just heard from others that had PCOS that it was a really rough recovery with the retrieval because they retrieved so many in just that process because of growing so many follicles.
Perfect. Yeah, like I said, I have to go off just for time's sake. We're going to go over that, and then we're going to answer other questions some people have. So she brings up a great point. I think I get people to say this to me all the time. They're like, well, if I make too many eggs, it's going to hurt the quality. And I try to explain to people that, no, the number of eggs doesn't really hurt the quality. And we know this because we put donors, like we give them so much medicine. We force them to make a lot of eggs. And usually they do just fine. We use a Lupron trigger. They have, they do very well afterwards, not in tons of discomfort, like that. And their eggs are beautiful. So we know it's not really just making a lot of eggs is the problem. Really what the issue is more of the quality of the environment. And I know for myself, and I'd love to hear what Dr. Salem says, when I have a patient with PCOS, there are things I have them do to focus on reducing that inflammation. It is true, if you give a patient with PCOS and you stim them very lightly, and you only make like 3, 4, 5 eggs, you're going to have some really good embryos potentially because you're not getting those high estrogen levels, the inflammation is not going up, and you can even get away with a fresh transfer. When you stimulate someone with PCOS, though, you create a lot of inflammation. And the hard part is that it's a certain type of PCOS patient that this happens to. So there are people with polycystic ovaries who have a pimple or two, and they'll have beautiful looking eggs, and you can make up 25 of them, 30 of them, and no problems. But then there are people who have things like acanthosis nigrans, which is this brown discoloration in the back of their neck. And there's signs of insulin resistance, such as central obesity. And those patients will act a little bit different. At that 25, 30 egg, their quality goes down, which is what you're talking about. And so the things I do is I go towards that inflammation. I try not to, blow them up with tons of medicine, but I try to make sure you get a decent amount. And then I have people do steroids. I have, so I'll put people using like a dexamethasone during their stim. I will also then have them be on like myoinositol or metformin if they show signs of insulin resistance. And then I have a lot of my patients do low carb diets during the stimulation. And I mean, significantly low carb, reducing all that inflammation. And I've actually had very good success with getting a lot of good embryos. And in the past, I didn't before I started doing this. I started kind of like thinking of ways to get this better. And so I'd love to see what Dr. Salem says. But I think one thing that's really important I want to point out is you mentioned about not having a lot of good embryos. When people get scared about IVF, they get scared about hearing these cases because they hear about these women who get 30, 40 eggs and they post on Facebook and then they say, I only got one embryo. Anytime you hear that story, it's either one of two things. It's either a PCOS patient and there was that inflammation, or there was bad FERT. But realistically, it doesn't happen to most people. But love to hear what you have to say, Sam, because it is a very unique group. And I feel like it's really important to watch them very carefully and to manage that inflammation.
Yeah, I think one of the things, just like you're saying, is, you cannot ignore PCOS, right? PCOS is something you have to manage it really, really, really tightly as you're going through the run up to an IVF cycle, the IVF cycle itself, the trigger shot, all of it. And that's when you can optimize the number of eggs and the quality of the eggs. So I really also believe that insulin resistance prior to your IVF cycle and during your IVF cycle plays a big role. So I'm probably like a broken record with some of my patients where I'm like, please, like, let's go really low carb. Let's, and it doesn't mean you have to go hungry. I mean, you can go low carb at Chipotle, right? But you just need to really focus on, having a low carbohydrate diet, very low sugar added, these little tips and tricks like walking after meals to just kind of ramp up the use of that sugar to get it out of the bloodstream, that kind of a thing. But then there are a lot of little tricks in our back pocket during the stimulation. There's the very fine titration of the medications because women with, certain types of PCOS, very high AMHs, a lot of follicles, even a very small dose adjustment can really change their response to things. And so you have kind of a narrow band to work within. And I think that becomes a very, very important part of it. So I think the key here is never, ever, ever, ever ignore the PCOS that you're dealing with. I think I shouldn't say a lot. I think there are some fertility doctors who are just like, PCOS, so easy, piece of cake. This person's going to get, 20, 30 eggs. And I'm not going to worry about them. They're going to be easy. And I think that's a mistake because I think, you really can shoot yourself in the foot by getting a lot of poor quality eggs. The other part of it is, of course, hyperstimulation. I mean, I think what the horror stories on Facebook and, online and all this kind of stuff happens when you ignore PCOS. And when you ignore the fact that there are many eggs growing and you don't do all these little things to avoid that hyperstimulation response. And we know that, we can have very, very, very good success and get extremely low rates of that kind of more severe type of PCOS. Now, are you going to be bloated and feel a little not great after the retrieval and everything if you get 25, 30 eggs? Yeah, I mean, probably, yeah. Realistically, you're not going to feel like you want to go to a wedding the next day or something. But I think there is a margin that we can really fine tune there.
Yeah, it's definitely, as you said, the doctors who focus on, customizing the treatment, I think are going to have better results. But I think it's always important to understand that spectrum of PCOS. I mean, there really is a big difference in the spectrum, and there are some that it's going to be worse for, and anything you can do to reduce that insulin resistance is always going to help. Insulin resistance is what creates lots of the inflammation, creates lots of problems. We know it does. And so one of the questions I saw someone when I was coming by was, does it help with even like a low carb diet during transfer? So I don't know. I don't think I haven't seen a study yet that's looked at that. But what I can tell you is it never hurts to reduce insulin resistance. We know it creates so much havoc in the body. And so anytime you can do anything to it, it's only going to help. It's not going to hurt. So you're never going to hurt yourself by doing that. I know you and I kind of like pontificated forever in the beginning for a while there. And so I thought maybe we can go to spend a few minutes just to answer questions that people sent in, especially the ones that we had. So we got a bunch of questions here. I was going to try to hit some of them early. One of them I thought was a great question was, does a low AMH indicate early menopause? And I think this comes back to that question of, well, like we were saying, it doesn't define like what's going to happen in the future. It's just there could be an association with this. So I know, and Dr. Salem, you can jump on this. I'm going to give a simple answer, which is no. It does not mean you're going to go into menopause early, but it does mean you may have harder time with future pregnancies or things like IVF. But menopause is very specific. It's a little bit different. That's not getting a period anymore for a whole year. And that is a very specific diagnosis that unfortunately AMH can't predict well. And that's been shown that really does not predict when menopause is going to happen.
Yeah, I totally agree with that. I think maybe there's something interesting with this concept that I dub reproductive lifespan, right? So that's kind of the years in which your fertility is still there, right? Like you can definitely get pregnant or get pregnant at a high enough rate. And I think there's probably some association between AMH and reproductive lifespan, but that research has not been shown yet. But definitely no relationship strictly with menopause.
I think it's a really great point you brought up, which is I think sometimes we think of menopause as the end point, and it's really not. The reproductive lifespan is done before menopause. Mm-hmm. So this kind of thought that, oh, when I hit menopause, then I can't get pregnant anymore. Most women can't get pregnant even well before menopause. And so I think you really, that's a great way to say that. I like that. I think I'm going to steal that from you. So from this point on, I'm using that term. And it's exactly what you said. It's not going to make menopause maybe come earlier, but your reproductive lifespan might be shorter. And that's a great way to say that. One person asks is, can high blood pressure affect fertility? I'll let you start with this one, Dr. Salem.
Yeah, so this is a great one. I mean, high blood pressure is definitely something that gets my attention because what we know is that high blood pressure can affect, all the small vessels throughout the body. And there are many small vessels that are feeding the ovary, especially where the ovarian cortex is. Now, there's probably a range, right? So the first thing in terms of ovarian reserve, on the very, very, very far end of having kind of, the types of conditions that cut off blood supply, we think of things like ovarian torsion, where the ovary has twisted on itself and it's not getting any blood flow for some time. That can definitely affect your ovarian reserve because there was no blood going to the ovary for 24 hours, let's say. And even if the ovary kind of survives, you see that the ovary doesn't have as many follicles and that kind of thing anymore. On the other side of that is like, oh, I have a little bit of high blood pressure that maybe I control a little bit with some mild medications. Does that affect ovarian reserve? I don't believe so. And again, I'll defer that to you, Dr. Amols, but I can't think of any research that shows that relationship. Now, where it does really matter as a fertility doctor is we're in tune to anything that's going to, not optimize your pregnancy. So we want to make sure that prior to getting pregnant, you have a healthy pregnancy, you stay pregnant, and you don't deliver at 32 weeks because you have, rip-roaring preeclampsia. So I think, while it might not directly impact your IVF cycle, it's still a big part of what we think about. But I'll toss that one over to you, Dr. Amols.
Yeah, I mean, I agree with you. I think the thing that we know is we know high blood pressure can definitely affect tissues, right? It's the high pressures there over long periods of time. It can affect things, affects the vessels. But most young women don't have high blood pressure, especially during this time that we're seeing them. it'd be very difficult to do that type of study too, because it would have to be, you know, the mild high blood pressure is probably not going to be an issue. You know, the ones where your doctor says, okay, change your diet, exercise a little bit more, probably not going to have much effect. But the people who have serious high blood pressures, I think it's plausible that it could affect it. But as Dr. Salem said, I've never seen anything like specific to say, hey, watch out with people who have high blood pressures. It might affect their fertility a little bit more. But there are medications that can affect it. So definitely if you're trying to get pregnant and you have, let's say, severe high blood pressure and you are on medications, it's important to talk to your doctor about what those medications are and make sure they're okay, not just in fertility, but also in pregnancy as well. Yeah, I agree. It's something where I don't like I said. Now you have me wondering. That's what I love about this show is I'm gonna go on later and go. I gotta go read about this. So maybe the next show I'll be like, guess what? We were wrong. So that's something I'm gonna look up. I feel like I would have heard something over all these years if there really was something, but I'm definitely gonna look at that. One question that's definitely on topic here was they said with a high FSH and a low AMH, is the best option IVF, or does it vary on the patient? I know what I mean. I know what I have. And I think anyone that listens to my podcast knows what I say about this. But I'd love to hear what you have to say. What do you think about that? Does that mean they need IVF?
Yeah, so I mean, it depends on a few things. Does it mean you need IVF solely? No. Actually, you know, you're in certain circumstances, depending on age, depending on a few things, maybe IVF isn't even the best solution. Maybe there are better solutions to try to get pregnant month after month after month with, you know, trying to get multiple follicles to grow and doing IUI. Again, there's a range there. In any given cycle, usually IVF is going to be like the dominant, you know, treatment, right? Like it's gonna have always a higher pregnancy rate per cycle. But there's a certain point where you start getting pretty close. Like, you know, in certain cases, like IUI might be 15% chance of success, but you've got an IVF cycle over here that's like 60% chance of success. Well, there's a big difference there. But as you get to these points where maybe the FSH is getting really high, the AMH is really, really low, you're only growing one egg every month, you know, it's a lot closer. And then you're starting to think, you know, it becomes a very personal decision as to whether that difference is worth it. I think this is a very case dependent thing, but I'd love to hear what your take is on this, Dr. Amols.
That's exactly what I talked about in my podcast many times. As I said that, you know, it doesn't mean you need IVF. And I would even get to the point, like you said, where some people, I think IVF might be bad because I look at it as this idea that there's a pot of money, right? I mean, in the end, not all of us have the benefit of insurances cover things. And so for most of us, there's a pot of money, right, that we have, and this is all we have. And my wife and I, unfortunately, we had to wait 6 more years to try again because that pot was empty. So if you have this pot of money and you're someone who can get a bunch of eggs with IVF, then it's almost always worth it to do that in that situation because you're like, hey, I'm going to get a lot of eggs, more chances. But if you're one of those women who might only get 2 eggs or 3 eggs, and you look at IVF and go, I can only afford 1 IVF cycle, but I could do 3 IVCs or I could do 10 IUIs, and there's nothing preventing them from getting pregnant. So again, this is someone who just comes with it, you know, low levels, and they don't have like a severe sperm problem or you know, blocked tubes. It might actually be not just cost effective, but better chances because if you think, listen, if I do 5 IUIs and I'm getting 3 eggs each time, that's 15 eggs over those versus 1 IVF, I get 3 eggs. And so when I look at it from that standpoint, I do think there's other treatments. My analogy, I think I gave this analogy in the podcast, was I always say like everyone can agree that a car is better than a skateboard. I love skateboarding, but the car is going to get me further, right? It's a better form of transportation. But if I only want to go 30 feet, the skateboard is actually a little bit better than the car because the car, I get in, I got to get a seatbelt, you know, turn it on, go over, drive 30 feet, get out and stuff. Skateboard, I jump on off in a few seconds. And so sometimes just because something's better doesn't mean it's better in all situations, which is what you pointed out. And that's exactly the point there is it never means you need IVF. But there are times where if you're a good candidate for IVF and your ovarian reserve is low, you may want to do it because you want to preserve fertility. You want maybe a future child. or for other reasons. So yeah, I agree with you 100%. And I know we're at the end here, but there was one question that is exactly what I was hoping people would send in. So we got to hit this one because of exactly what I said. Send in your thing. And so from Abby Frog, she wrote, 27 years old. I have an AMH of 0.58, an FSH of 7.8. This was 6 months after miscarriage labs on day 3 of my cycle. And so I just, if I saw her as a patient, I know I would tell her that, that AMH is concerning. 0.58 for a 27-year-old, that worries me a little bit. Now, obviously I need to know more information. As Dr. Salem has always mentioned, there's things that can affect those. The FSH is hard to know because we don't have the estrogen level. That's one thing. Never worry about an FSH or think it's good or think it's bad without an estrogen, because it doesn't mean anything. Without the estrogen, we can't tell if it's actually a valid FSH. But I would be concerned. And, the question is, I would want to know more about the miscarriage too. Have you had multiple miscarriages? Is there some type of trend here with egg quality? And so, Dr. Salem, I will end with you. And I think this is a perfect question because that's what we want to do, is look at these people's ovarian reserve and talk about it. And what would you say to someone who came in just knowing that stuff? Obviously, we don't know anything else. What would you say?
Yeah, I'm definitely one of those type of doctors that's not like alarmist. I'm not like, let's go and test everybody under the sun for their AMH. And oh my God, you had an AMH that was just a little bit below average. But this one will get my attention. And I would say, hey, this is far enough away from normal for somebody that's young like you and presumably otherwise healthy and everything, that we should look a little bit further. We should look a little bit further, like, did your mom have an early menopause? Was there something else in the background? Did you have surgery recently on your ovary? Let's kind of dig in a little bit deeper. Let's not ignore this. There are certain values where we can say, yeah, that looks good. That's close enough. That's not a problem. But then there are certain values where we have to kind of tune into it and say, let's be a little more proactive. And this is where our, field really excels, I think, now is being more proactive. And this might be the kind of person that wants to eventually consider egg freezing or embryo banking. Because again, this goes back to that topic of reproductive health span. I don't know this about this person, but let's say we looked further into this and we found that there were something in the background that would predict that the reproductive lifespan might be shorter than it really is. Then, hey, the silver lining is that we have an opportunity to preserve your fertility. You might still get to build the family that you envisioned and dreamed of. And maybe, 50 years ago before IVF, that wouldn't have been the case. And so I'm really glad that you asked that question and that you put that forth. And I think this is a really great one to end on as well. But, I really enjoyed this topic. This was a great one, and really glad that we got a chance to kind of go back and forth, listen to some of what our listeners are thinking about and what their AMHs are, their specific scenarios. And so, yeah, over to you, Dr. Amols.
Yeah, I just was going to mention, Abby, if you haven't seen a fertility doctor, it might be worth seeing one. Even if you're getting pregnant easily, that is, like, as Dr. Salem said, a little bit off from where we would expect it. If this was, you were 40 and I saw that number, I'd say, okay, I mean, I'm not too worried. But it's a little far off, so please definitely see someone if just get checked out. Like you said, you could figure out something else or even be able to potentially preserve your fertility. So I was going to bring Ari on because, again, like, Ari is the person in the background who's doing all this stuff. We just get to sit here and talk, like, and answer questions, but she's the one doing all the work in the background. So bring her on and, thank her for again, helping us every time we do these shows. And she's the one who's actually getting your, we put a question in, she's taking out your name. She's the one who's, making sure if you get 5 or 1, and we're gonna do it for several months. Then we're gonna, we'll draw, live, we'll draw that, and someone will be winning things, and we'll have other stuff too in the future. But Ari, thank you so much. I know we do really appreciate you because we literally could not do this without you. If you ever saw that show you weren't on, it was really bad.
That's funny. Now, you guys have the fun job getting to answer questions. Thank you all for participating and sending your questions in. If there are any questions that we didn't get to, we have them in our queue. So don't worry. I am taking note of them to answer for the future shows. I have also put down all of your names on a spreadsheet. So if you're worried about if I seen it and if I got your raffle entry, we definitely have it. We have it all organized for you. Also, we had a lot of new viewers tonight. So thank you so much. If you're new to New Direction, thank you for joining us. We see a bunch of different people, but thank you. Keep joining, share this live whenever we go live on Facebook and Instagram and YouTube. Share, because the more we can get it out, the more we can help people. So thank you guys for joining tonight.
Thanks so much. Well, you guys all have a great night. Dr. Sam, have a great night. And Ari, see you in the office sometime soon. Talk to you later. Bye-bye.